The mission of the school is to meet the healthcare needs of central and southern Illinois. And that, as you know, is a largely rural population. And it means that the people that work in those settings, most of them need a broad and general skill set. They don't need highly specialized surgeons who only want to do a limited number of operations. They need people with a broad set of skills who enjoy being a generalist and having the variety of experience that you need to function in that kind of setting. And actually, I think that's a harder job than to be a super specialist, because you have to have a pretty broad set of cognitive and technical skills that you keep conversing in. And the challenge we saw is that if the residents never spend time in a smaller setting like that as they go through their training, it's hard for those that haven't really considered it to catch the vision for what a practice like that would be like. Or for those who come in with the vision, it's hard for them to sustain it. So we thought, if our mission is to meet those healthcare needs, and for surgery, that means turning out a product that has broad skills and an interest in practicing in such settings, we need to provide some type of experience during residency that allows them to explore that or to experience that.
I thought it was an exciting opportunity, a little bit of variety from what we have here. Give us a chance to work just one-on-one with all the surgeons. It'd give us more cases, more volume, also a choice of variety. We can pick from thoracic cases, ENT, obstetrics, general surgery. So all around, I was excited about the opportunity.
Another reason is that we're in an era where, because of duty hour pressures and other changes in how graduate medical education is accomplished, there's been pressure for residents to get the same amount of case volume experience in a traditional teaching setting than there was 15 or 20 years ago. Most programs have done this successfully, but there's been a lot of adjustments allowing it to happen, not all of which have been educationally profitable. In fact, some of which have been educational liabilities, like increasing handoffs in care and lack of a in-depth sort of apprenticeship-like experience for residents with faculty. So the rotation in Carbondale, because there's no other surgery trainees there, and the residents therefore can have an immersive experience with more faculty than they could do all the cases for, gave us a chance to put them at a level where they've already acquired some of their basic technical and cognitive skills into a setting where they could do a larger amount of operating in a relatively short space of time.
I only heard positive things from all the other residents. The one nice thing is that they got to operate all day, every day, and so all of them raved about that. They're all excited about the attendings. They're all very friendly, very amenable to teaching and allowing us residency level appropriate responsibilities within the OR. I think the variety of the practice of the general surgeon, because there's no subspecialties within general surgery. The general surgeon did everything from gallbladders, appies, and then did more complex cases, and some cases that a specialty would cover, like colon cases, the general surgeon would do there. So I think the breadth of practice was interesting.
Or sort of an operatively rich experience for the residents in a setting that helped them see the breadth of what a general surgeon can do when they practice in a smaller, less tertiary, less quaternary environment than they often see in their training years. So those were probably the primary motivations to do it. Related to that as well, I would mention that if you look not just about central and southern Illinois, but if you look at demographically what our society needs in surgery, many smaller hospitals stay open or close based on the presence of a single general surgeon, because the revenue stream that goes with a surgical practice and the other things you can start to do at the institution in other disciplines if you have surgical backup make the institution much more fiscally viable. And we need places, critical access type capabilities all over the country. That's what we need. We don't need more people who only take out a left adrenal glands, And it's an extreme statement, but there's a lot of our residents are being trained in environments where they think that if they don't become super specialized, they will not be useful. And in fact, from a societal point of view, it's quite the opposite that is true about what we need. So we felt like to do this is aligning our treatment goal, or our training goals with societal need, with our regional mission, and then with an opportunity that in a new era of medical education with lots of pressures really gives the residents the kind of operative experience that we want to be part of their training.
Yeah, I would absolutely recommend this rotation because, like I said, you get to operate all day and every day, and so that allows you to work on your skills instead of having big breaks in between doing, say, a gallbladder. You do one this week and another week. You might do 5 or 6. So once you repeat that operation so many times, you learn the steps of it a lot more fluidly and easier, I found. So I think all in all, it's a great rotation. You learn, you get to develop your operative skills, and you're the only resident there. So you can pick whatever case you want to do. So the variety of cases you get to learn, and just the repetition of each case is a great opportunity.